everybody to our TIF Talk. Thank you for joining us. I'm very excited to have our special guest here tonight, Dr. Paul Severson. Welcome, Dr. Severson, and thank you for being here with us today.
Thank you.
You're welcome. So before we start, I did want to remind everybody that this is a live event, and at any time, if you have any questions for Dr. Severson, please feel free to type them into the comment section, and we'll do our best to answer all of the questions today. Before we start, I'd like to introduce Dr. Severson. He is the medical director of the Minnesota Reflux and Heartburn Center, a joint partnership between Riverwood Healthcare Center and Cuyuna Regional Medical Center in Minnesota. He is the chief of surgery at Riverwood in Aitkin, Minnesota. Dr. Severson is the co-director of the Minnesota Institute for Minimally Invasive Surgery and the program director of the MIMIS Fellowship in Advanced GI MIS, Bariatric Surgery, and Flexible Endoscopy. He has served as president, board member, and committee member for several regional, national, and international professional organizations. He is the founder and president of Project Haiti, a 501c3 charitable organization providing humanitarian relief to the impoverished people of Haiti for over 3 decades. His areas of published expertise are in advanced minimally invasive surgery and endoscopy, foregut surgery, and bariatric surgery. Again, thank you so much, Dr. Severson, for being here with us this evening.
Such a pleasure.
So we're going to talk about GERD today. We're going to go ahead and start. Just to introduce myself, if you don't know me, my name is Andrea Millers, and I'm with Endogastric Solutions. And we're going to talk about GERD and the TIF procedure. So Dr. Severson, do you want to start talking about what is GERD? Maybe give us a scientific explanation of what it is. What could patients potentially feel, or what types of symptoms would they have if they were suffering from GERD or chronic acid reflux?
Sure. You know, GERD, a lot of people don't even know what that means because it's an acronym for gastroesophageal reflux disease. It would more commonly be thought of as heartburn. The problem is that heartburn really only occurs in people who have reflux, which is why we named our center Minnesota Reflux first. Heartburn is the way people think about it, but gosh, if 40% of people don't even have any heartburn, that's a problem. They might have a lot of other symptoms.
Right. Point. So what types of symptoms, like typical symptoms, would a patient feel, or atypical symptoms? You know, is it just the heartburn feeling? I often hear patients talk about, you know, I had to go into the ER. I thought I was having a heart attack. It turned out it was GERD, you know, trouble sleeping. What are the different types of symptoms? Yeah.
Right. So the one that I think is most important for us to focus on tonight is going to be the effects of regurgitation.
Sure.
So even though it might not burn the esophagus, as the acid or bile comes up into the chest, it might regurgitate as far as our throat, up into our mouth. This could cause a lot of problems. This could cause hoarseness, affect our vocal cords. It could cause sore throat. It could cause bad breath, dental erosions, and a host of pulmonary or lung problems, you know, like coughing, particularly at night, asthma, bronchitis, pneumonia, aspiration pneumonia. So there are far-reaching side effects of this particular disease. And the regurgitation is something that we should be talking about tonight, because that's not something that's going to be fixed with medicines.
Point. What are currently, you know, before you get into, you know, surgical options, maybe you could talk a little bit more about medical therapy. What are the different types of things for potential patients to do to manage their GERD, you know, even before they decide that
Sure.
You know, surgical options right for them is right for them?
Well, you know, there's such a tremendous variation in this disease, because right now there's somewhere between 40 and 50 million people in the United States who are using some form of medication. And of course, initially, they don't go to the doctor. They go to the local store and they find something to put the fire out. And that's going to be maybe, well, it's calcium carbonate, but commonly known as Tums or Rolaids. Or maybe it's a liquid that they drink, like Malox or Mylanta or something like that. And these are things that you can buy over the counter, and there's lots of them. When you go to the store, it's unbelievable how many products are there. It just tells you how many people are suffering from this disease. So that's how people start out, but then that's not enough. So then they kind of graduate to other medications while they're learning about what lifestyle changes affect this disease. They find out that if they eat too much or they eat too late, if they eat a lot of fatty foods or greasy foods, then it stays in their stomach longer and can really make them sick when they try to go to bed too early. If they use chemicals, and Americans tend to love their chemicals, that's alcohol, that's caffeine. I know I love a cup of coffee in the morning, but that could cause a person with GERD, to really react to that and start to have problems. And then smoking or the use of nicotine from any source, these three chemicals are powerful relaxers of the little muscle at the end of our esophagus called the lower esophageal sphincter. And that causes it to relax. So if you go out, have some drinks, lots of good food, that muscle is going to open up and you're going to reflux your gastric contents up into your esophagus. And if you go to bed too early without digesting that, you may end up all the way to your throat.
So oftentimes, they talk about, people, it's sometimes common for people to have reflux, right? You eat too big of a meal, you might have reflux. At what point is a patient considered, having GERD, and when should they seek additional consult in regards to their symptoms?
Right. Well, I think then they'd have to go to the medicines next. And there's two different classes of medicines that people use. The one that's been over the counter for the last 30 or 40 years is the H2 blockers, they're called. And the common one, the biggest seller was actually something called Zantac or ranitidine, but they took it off the market last year. And so now probably biggest choices there would be famotidine or Pepcid or cimetidine, commonly known as Tagamet. And these are H2 blockers. Now, they're not as powerful as the real miracle drugs for this, but there's 6 different miracle drugs called proton pump inhibitors, PPIs. And these are powerful medications that block the little acid-producing pumps in our stomach, and they're very effective. And so when people get on that, they can take 1 pill or 2 pills a day and have amazing relief of their reflux. And they'll usually do that because several of those are available over the counter now. And so they can go to the store, pick it up, try it out. And so there's people who have been on these for many, many years. Now, it's interesting that if you read the label, it tells you that you really only should take it for 2 weeks at a time and 3 times a year. That's the original FDA labels for this. But doctors prescribe this for their patients, and they're on it for 10 years, 20 years, 30 years. And to get finally to the answer to your question is, I think if a person's been taking medications for 10 years or more, they should come to a place like a center like ours, or a place that specializes in GERD management, and have a procedure called endoscopy to look inside. And the main reason for that is because it can lead to cancer.
Right. I'm one of those patients who've been taking it longer than 2 weeks. So.
Right.
Well, I have to get my TIF at some point. But so we've got a couple of questions that have popped up already. So we're going to see if we can answer 1 or 2 of them, and then we'll continue with what we were talking about. So let's see. From John, he's asking, what is the most common atypical symptom that you see in your patients?
Yeah, atypical means not heartburn, because heartburn is considered the common typical symptom. And I did mention earlier when things get all the way up to your throat, that's LPR symptoms. That's what the medical people are going to call that. First, larynx, laryngopharyngeal. That's larynx, pharynx. So that's your vocal cord area, and then the back of your mouth, and reflux. So all of those symptoms that I mentioned earlier would be considered the more atypical symptoms. But people can get pain into the strangest places. It can go into their back, it can go up into their neck, their ears, they up into their sinuses. So there are people who suffer from strange and unusual symptoms. Maybe one of the more common throat symptoms that people come in and that I hear quite frequently is I feel like I always have to clear my throat. I'm clearing my throat all the time. I've got phlegm in my throat. I feel a lump in my throat. So that would be a common atypical type of symptom. You'd have to get it checked out to find out if it's due to reflux, but that would probably be the most common cause.
Yeah. Okay. Thank you. A question from Tony. She's saying, I've been on Prevacid for 20 years and want to get off. I've been told I have a hiatal hernia. Can this be fixed?
Absolutely. Yes. One of the reasons why we decided to establish a center here in Minnesota was because we can help people. We can help almost everybody. So if people come in and get evaluated with a comprehensive diagnostic evaluation, we can talk a little bit about what that is. We're very confident that we can make people better or even cure them and get them off their medicines.
And then from Lauren's asking, what complications could occur when taking medications long term?
Well, that's a great question, Andrea, because if you go back to the FDA's warnings. Now, I'm an older physician, so I prescribed these medications. I didn't follow the guidelines. Everybody was on them for years and years because honestly, by and large, they're pretty safe. But then in 2009, literally 30 years after inventing them, the first FDA warning came out. And there's been a steady parade of warnings to physicians since 2009. And it started with dependency issues, like if you tried to stop it, you'd be hooked and you'd have to go back on it. And then magnesium deficiencies, and then arrhythmias and Clostridium difficile colitis or diarrhea. And a lot of those things people go, I don't even know what that is. So that doesn't bother me. I'm just going to keep taking my medicines. But in the more recent years, we have stroke and heart attack and earlier death. And the German study with dementia, so we've got a lot of people, chronic kidney injury, where nephrologists don't want their patients on it. Cardiologists don't want their patients on it. History of dementia in the family, maybe not take it. So we have a lot of patients coming in who say, I don't want to be on these drugs for my whole life. If we have a patient that starts when they're 30 years of age, it might be on drugs for 50 years. Yeah. So if there's a simple solution to this problem that can get you off the medicines, a lot of people are opting for that, Andrea.
And you just scared me now. If I wasn't scared before about my 1 year of taking PPIs, I'm going, oh no, I don't want to be that person. Okay, well, let's talk a little bit about GERD treatment options. So do you want to kind of discuss what options are available today to treat GERD?
Sure. So we've already discussed at length the medicines, and you can do some lifestyle changes. You can change the way that you eat. If you reflux at night, you can elevate the head of your bed. You can put 6 to 8 inch blocks under the head of the bed. You can buy a medical bed. Those are fun. I see the commercials on TV, where the husband and the wife are doing each other. Pretty fun. So that's something, but it's very expensive. It might even be better to just maybe see your doctor and get it fixed than buying one of those beds. So this is once we leave the whole lifestyle change and look at alternatives to medicines, this is what's exciting and why so many centers like ours are happy to be able to talk to patients about options, because there's a lot of them now. Years ago, I'm a surgeon, and I really only had one option. It was called the Nissen fundoplication, and that's what we were taught. But that has a bad reputation now. It's not necessarily a bad operation. It can be done well, but it's what we call supraphysiologic. In other words, it's so snug and wrapped all the way around. We take the stomach, we wrap it around the lower esophagus, and it's so snug that people can have problems with swallowing. They can have problems with trapping gas, and therefore they get bloated and they have excess flatulence. And when people read about that, they go, I don't know if I want that option. So the Nissen fundoplication has gotten kind of a bad reputation, maybe somewhat unfairly, because really good surgeons can do that operation quite well with good results. But there's another type of fundoplication that's become way more popular in recent years called the toupee fundoplication. This is a partial fundoplication. And I have to tell you about it because when we do a partial wrap, actually the new procedure of TIF, which we're talking about tonight, is pretty exciting because it really kind of simulates or matches the efficacy of the toupee fundoplication, which is a great operation.
Right, right, right.
There's also other ones out there too, like Link's magnetic sphincter augmentation. There's the Stretta procedure. And then of course there's the TIF. What's exciting about the last ones that I'm mentioning is they're becoming less and less invasive. And that really appeals to people when they can think about, oh, you mean I could have a procedure and go home the same day? Wow. And I wouldn't even be on my medicines. I think I really need to consider that.
Point. Can you talk, before we talk about the TIF procedure and how that actually works, can you talk about the workup, the diagnostic workup that you do typically for patients prior to determining whether they're a candidate for any of these treatment options?
Oh, I'm so glad that you asked about that, because that is actually what separates a center that's dedicated to finding a tailored or personalized approach for the patient, because you need a lot of scientific information. It used to be that we just put a scope down the patient and we took a look and we'd say, oh, I think they have a hernia, or yeah, they really have a lot of damage to their esophagus. But we didn't really measure anything. And so we didn't have the kind of information that we really need today. Now, you would not bring your car into a garage today and have somebody just lean over and listen to it and, you know, kick the side or what. You would hook it up to a computer, right? And they would tell you every detail about every cylinder. Well, that's what we have to do to our patients. When they come into our center, in one day, we're going to do high resolution manometry with impedance. It's a test where we hook up the esophagus to a computer to see how functional the swallowing is. We're going to put an endoscope down with the patient asleep, and doesn't hurt. No, it doesn't hurt at all. And when we're doing that, we're going to do multiple biopsies. We call them triple biopsies now. We're going to get biopsies of the stomach, rule out a bad bacteria called Helicobacter. We're going to get biopsies, and we have many different ways now of biopsying the area where Barrett's esophagus occurs. That's right where the esophagus meets the stomach. That's where the cancers are occurring now. And so we are very concerned about offering every patient what we call a cancer risk assessment or oncologic analysis. We're really trying to tell them what their risk is. Do they have any risk? Are they starting to form Barrett's esophagus, which could lead to cancer someday? So we have not only traditional biopsies, but we have the Watts 3D brush biopsy system, which is excellent. We have the Cellvizio confocal laser endomicroscopy unit, which is the world's smallest microscope. We can actually look right into the cells, the Barrett cells, and see them. So we study that area carefully. And then at the end of the procedure, before they go home, we like to put in our center a Bravo 48-hour ambulatory pH monitoring system into their esophagus. And that's a clever little thing. It's like a little pill that we attach on the inside of the esophagus, and that talks through Bluetooth wirelessly to a little computer that you wear around your neck like a necklace. And after 48 hours, we have a complete recording of what actually happened to the patient. both day and night after eating. And this tells us exactly what's going on. That's how we scientifically diagnose GERD in a modern way today compared to a few years ago.
It's a very comprehensive evaluation to determine, what's the right treatment option, if you will. So let's talk about the TIF procedure. Do you want to explain to the viewers what the TIF procedure is and how it works?
Well, it's what I would recommend if somebody thinks, oh, I think TIF is for me. The website that's available at GERD Help is excellent, and you can see the animated visuals of how this procedure is performed. And once you kind of watch the video, I think that really helps. But bottom line is, we're actually performing a totally incisionless endoscopic procedure. So this is the first operation. Well, there's stretta as well, can be done endoscopically, but this is the first operation, so to speak, that actually very closely simulates the toupet fundoplication, which is the gold standard procedure surgically. But you don't have to make any incisions. The patient goes to sleep. We put this device, the TIF transoral incisionless fundoplication is what that stands for. Transoral, meaning through the mouth. Incisionless, meaning no incisions whatsoever, all done through an endoscope. And fundoplication, which means that it simulates a real surgical procedure. And so we place this device down through the esophagus and into the stomach. And by looking backwards up towards the mouth with a scope that's inserted inside the device, we actually take the stomach and we fold it up against the esophagus where that weak valve is, and we create a brand new valve. And so this simulates the toupet or partial fundoplication. And so people can burp afterwards, they can still vomit, they have all their natural reflexes, which they might not be able to do with a Nissen. And they don't get the gas and the bloating and the flatulence and all the negative side effects because it's partial. And yet it still controls reflux very well, so that between 80 and 90% of patients are off their medicines for good.
You talk a little bit about, I think you do it a little bit different at your location as well. What can patients expect if they are coming in and having the TIF procedure, prior to coming in? Do they have to stop taking their PPIs? And then also the day of their procedure. And it's my understanding that you actually have outpatient procedures. They get to go home that same day.
That's correct. And it's really correct. And it's really important that you touch on that, Andrea, because, we've all been living through the COVID nightmare here in America. And, people are very concerned. They don't know what to think. Should I get my procedure? Should I go to the doctor? Should I just wait until this thing is over? All these questions come up. And I want to reassure our public that the environment that we've created, at least here at our Minnesota Reflux and Heartburn Center, is so safe. I don't know if you're going to be in a safer place during the whole COVID experience. I think you're way more at risk just going to buy your groceries than you are coming in to have an outpatient procedure. We don't have to worry any longer about the hospitalizations and the bed space, the ICU and all the things that you hear about, because all of our anti-reflux procedures, and particularly TIF, is done same day. You're home sleeping in your own bed that night. So there's no concern over mixing with other sick patients. We come in a separate entrance. All of our nurses and doctors are completely protected with this amazing PPE. And so, it's totally safe to be able to come in and get it done, even in the COVID environment. And, honestly, we probably learned some things from COVID. This may very well continue into the future because everything is so clean and the patients are so protected. So I don't see, I would not hesitate to have one of my loved ones seek diagnostic evaluation and then proceed with a surgical procedure or an endoscopic procedure.
That's great. I did have a question that just popped up. What if they have a hiatal hernia as well? Do they go home same day too?
Actually, they do. Actually, they do. And I should say that, the majority of people actually have a hiatal hernia. And the TIF procedure is not designed for people who have a big hiatal hernia because you have to fix that. And that does require a laparoscopic operation. Now, that's still minimally invasive. You still get to go home the same day. The hiatus is repaired, and you can either, if the surgeon wants to do a toupee fundoplication or wants to stop at that point in time and then do a TIF procedure endoscopically, you're going to get roughly the same result. So, and that's really the surgeon's option, and that should be tailored to the individual practitioners and how skilled and what they're good at and what the patients desire.
Sure. And so they'd be able to go home though the same day as well if they had both. Okay.
Yes, absolutely.
And what about kind of the post-op recovery phase? Everybody talks about the diet and being able to transition to the liquid diet. Can you talk a little bit about what your protocol is for post-op?
Yeah, I think most of the protocols around the country are very careful, very conservative, because they don't want to stress this new arrangement. People say that their reflux symptoms go away immediately the first day, but we don't want that to heal in place. And that really takes a good week or two before there's bonding of the stomach wall to the esophagus to create that new valve. So we really stress liquids to begin with. The same day of the surgery, they're going to be on clear liquids. The next day, we in our institution do allow people to go to full liquids if they're swallowing well without any symptoms. Some centers want people to stay on clears for a whole week and then a whole second week of full. We're a little bit more liberal with that. It's still liquid. It's just that we liberalize what the liquid is. And then after the first week is over, if people we're going to see them back in the office. Oh, and we might be doing a virtual visit because of COVID, and that's fantastic. We could we can look at their little wounds on their computer, their iPhones, and then if they're doing well and they can swallow well, we're going to be a little bit more liberal in allowing them to advance their diet. But they're not going to really be up to a kind of a normal diet for at least 3 to 4 weeks. And we're going to be cautioning them to avoid carbonated beverages, meats and breads, things that tend to get kind of stuck in the esophagus. That's the last step in the diet. But it's people are so happy because there's no pain by the end of the first week. When we see them back, the reflux is gone, the pain is gone, they're back to work. They were there for 1 day at the hospital. And for all the years of misery that they went through, all the pills that they bought, I don't know if we have happier patients, honestly.
Wow. So you mentioned some briefly about patients going back to work. What's the protocol on that? And we get a lot of questions about exercise. What do you normally tell your patients?
Well, it really depends on what their work is. If they're not in a job where they have to lift much, then they can go back to work, 4 to 7 days post-op if they can not lift, or if their job allows them to have adjustments to their work so that they don't have to do a lot of lifting. We don't want to stress our repairs for the first 6 weeks. That's kind of a standard across pretty much all of major surgery that's abdominal. Even though there's no incisions, that area of the diaphragm there's a lot of force that's exerted against that when people lift or strain. And so we really want to have a kind of a quiet 6 weeks to let everything heal in place before they're going to be allowed to go to heavy lifting or vigorous exercise.
Okay. Well, thank you. We've got tons of questions. So
That's great.
I'm gonna get through these questions so we can answer some of them. Let's see. What can you take? Debbie's asking, what can you take once the acid has come up in the throat and chest and is burning and you're coughing? Is there anything to stop that burning and coughing?
There really isn't, unfortunately, because that's a mechanical failure of the lower esophageal sphincter, or that valve that I'm talking about. And no medicines are able, that's a physical, mechanical problem that's taking place. And the medicines, that's exactly the patients who should be seeking help and getting that valve fixed, because there really isn't any medicines that are really going to help the patient. You have to do what I said earlier, where, eat a smaller meal, eat earlier in the day, maybe like the European families that have their bigger meal at, noon, a smaller meal in the evening. Make sure you're done by 6 o'clock, and then you stay up for a good 3 to 4 hours afterwards, so that all of that food is already processed and out of your stomach. And then at night, we don't produce much acid. So then you're going to have a much better night. You're not going to regurgitate much at night. So those are things you can do. And of course, those nighttime regurgitators have to have blocks under the head of their bed or a medical bed. Otherwise, they're going to have a miserable night. They're going to have poor quality sleep. They're going to have difficulty working the next day. But if you've got that kind of regurgitation going on, you better come in and see us.
Good point. Good point. Arrow is asking, what other digestive issues do we get with GERD? And I know you talked a little bit about, progression of GERD and potentially Barretts and whatnot. So maybe you can just revisit that again.
Well, just in terms of symptoms, it's very interesting that as people progress in their GERD, they swallow more and more. And the average person swallows about 2,000 times a day. Somebody studied that. I can't believe somebody counted it, but they did. And so what about the GERD patient? Well, actually, that's the only natural self-defense mechanism that you have, is to swallow your saliva. And that's maybe why gum chewing can kind of help a little bit. You create more saliva and you swallow, and therefore you clear the acid out of your esophagus. So, but this is not good, because every time you take a swallow, you gulp a little bit of air, atmosphere, and then that goes down into your stomach and it can go through your bowels. And so we always do an inventory on patients to check to see how much bowel problems they have. And it's amazing. They have a lot of gas, a lot of belching, bloating. And then the thing you have to be careful about is, once you do an anti-reflux procedure and you're fixed, you don't belch all the time because you have a valve now. Well, then all that extra air that you're swallowing, it goes through you. So you get bloating, flatulence, etc. Now that settles down once the brain figures out that the patient's cured, you get better fast. And that's one of the advantages of a TIF, is because of all the procedures, that may have the best side effect profile with very little problems with gas and bloat.
Good point. So Becky's asking, do PPI meds work if you have had stomach stapled given absorption issues with medicine?
Do they, is the question directed towards treatment, medicines, or surgical revisions, or what?
I'm assuming she's had stomach stapling.
Yes.
And she's asking if the PPI meds work.
Well, okay, so that it's a great question, and I'm glad somebody asked something about the bariatric or weight loss type of procedures. That whole area of bariatric or weight loss surgery has changed dramatically over the last 20 years. We used to have large gastric pouches, or you still could produce a lot of acid. You could still reflux. Some of the older operations actually were reflux producing. So if they have an older operation, they might need to have that changed. So again, it's very important that they seek expert help in a place like ours, where we do both the anti-reflux procedures and the bariatric procedures. A modern, well-performed gastric bypass procedure has a very, very small gastric pouch that makes acid. We're talking less than the size of a golf ball. So there's no way the acid from the stomach can get up into the esophagus in a properly performed modern stomach stapling. But stomach stapling is kind of an old technique and an old saying. So that might be someone who had it many, many years ago and needs to have that reevaluated. There might be real help for that patient. Medicines can help, but it's the same as anybody else who's got reflux problems. You have to go look to see if the mechanical problem can be repaired.
It's a very, very good point. Well said. So Wendy is saying, it was the best thing I ever did. You did my surgery in 2005 and still working great. Thank you.
Wow, that's good. Wow, that's good. 15 years with one operation. That's great.
And then we've got a comment here from Timothy. If you're diagnosing it, fine, but somebody that's taking Prevacid for their whole life, I'm trying to read it. So just need it fixed. And I've had a surgery where they went in and put probes down there and he did it or something to make scar tissue. And that didn't last long. I opted out for the stomach wrap because I thought that was too invasive and could have too many side effects for swallowing. Sure. But I
it sounds like what was this patient's name?
Timothy.
Well, it sounds, Timothy, like you probably had what's called a stretta procedure, where the little probes you're talking about create radio frequency energy, and that tightens up that little valve area. But that's very common for that to only work for a period of time or perhaps fail. It's probably considered the weakest of all the procedures that we do. But listen, just because a stretta fails doesn't mean you can't move to the next thing. You had an endoscopic procedure. Maybe a TIF is in order. That's another endoscopic procedure that's much more robust. Or maybe you should talk to a specialist about getting tooth fundoplication. It's same-day surgery too. You shouldn't be so scared of it. You should be more scared of this disease, not of the procedure.
So Warren is saying, asking, can you get the TIF if you already had a hiatal hernia operation 2 years ago that didn't work?
Hey, we're getting some incredible questions.
I know.
So probably one of the most exciting things for me as a surgeon I'm not a gastroenterologist who performs this, I'm a surgeon that performs it, is the fact that people who have had loosening of old Nissens or loosening of old toupees, I can use the TIF device to tighten them up without reoperating, without doing a revisional surgery. So for me, that's one of the most exciting things about this. And one of the reasons as a surgeon why I decided to jump into it and join my colleagues across the country who are really liking this procedure.
Perfect. So Debbie is asking, what if you also have liver bile reflux and beginning of Barrett's?
Okay, so Barrett's is the precancerous cells that are formed from long-term reflux. If you've got Barrett's, you've had reflux for a long, long time. Andrea, I don't think if you've only been on PPIs for a year, you probably don't have Barrett's. It probably takes a good 10 years or so, before you're going to be getting this. Oh, and by the way, the medicine does not protect you from Barrett's or cancer. That's important to know. You can feel better and you think you're okay. But remember, we've had over a 700% increase in cancer of the esophagus coming from Barrett's in our country in the last 3.5 decades. So if the medicines were working with 40 million, 50 million people taking it, we should be seeing cancer rates going down. We're not. We're seeing them going up. So people should never presume that medicines are protecting them from ongoing damage from bile. It's true that you're getting rid of your acid, but bile is very toxic. There's many doctors who believe that the bile may be even more important in terms of being the underlying inciting factor for the development of Barrett's and cancer. So when you start to get these advanced signs, it's our opinion that you should do something more than medicines. You should really be seeking help and trying to get control of this disease before it's too late.
Good point. Very good point. So Donna is asking, how long is the process to get this started?
Well, okay. So when you call like Minnesota Reflux and Heartburn Center, one of the great things about our center is that we have a team approach. So we have a nurse coordinator, and we have 2 different sites. We're so busy, we have 2 different, we have 5 people doing these procedures, the surgical people, We have 2 GI labs that are studying all this, and we have 2 nurse coordinators. Riverwood is one of them, and then Crosby or CRMC is the other one. And our nurse coordinators, Dawn and Leah, they're phenomenal, and they're on the website. And when you call them, they will answer just as well as I did. They'll answer all the questions that you have, and they will get you all set up for your diagnostic evaluation, and they will guide you. We call them nurse concierge. It's kind of like a fancy hotel. You know, they help you through everything from beginning to end and hold your hand the whole way until you're fixed. And not only that, we continue, you know, it's a lifelong disease. So you're not necessarily just done. I mean, I appreciate the call from the 2005 operation, but, you know, sometimes people need revisions. We've had several calls tonight on people who are having some troubles with past procedures. And so they should come in and get that, they need to get fixed too. And revisions we do them all the time. So these are patching up old problems.
Good point. So Don is asking, what are warning signs of Barrett's versus GERD? So are there warning signs for Barrett's?
You know, again, very important question, because here's the problem. As you go through life and you start off with classic heartburn, and it burns your esophagus, and you take the medicines, the more damage that takes place to your esophagus over the ensuing 10, 15, 20 years, the less you feel. So the people who get cancer of the esophagus almost never have any pain. They come in, they're shocked. They say, I don't understand, doctor. I haven't had heartburn since I was younger. Well, they've been refluxing, but their esophagus is so damaged and so burnt and so scarred and so filled with Barrett's that they can't feel it anymore. So this is why in the very beginning we talked about, well, when should a person come in? And I mentioned, well, if you've been on taking pills for 10 years and you think you've had this disease for 10 years, you really should get it checked, because you don't know if you're one of those patients that developing Barrett's. 10 to 15% of all GERD patients will develop Barrett's.
So Don is asking, do I need to see my regular doctor? So obviously their GP or PCP, you know, first to set up an appointment with you or a surgeon or even just a specialist. So across the board.
Well, not at our center, because we have a center with direct access to the nurse coordinator who can then set it up, and she'll do all the communicating with the primary care, et cetera. So you can come in directly. But I should remind people that some people have health plans that require them to go through a gatekeeper primary care doctor first before they would see any sort of specialist. That's not so common, at least here in Minnesota. But you know, that can be a consideration. Sometimes they have to go through that, but not usually.
We've got some very advanced patients asking questions. So this question is, how do you avoid hitting the vagus nerve in the procedure? I have heard of some people developing issues with the vagus nerve after these types of procedures.
Correct. Yeah, and that's one of the appealing things for a lot of patients. I think I'll get a TIF because I don't want the surgeon banging up my vagus nerves, which can slow my stomach down afterwards and give me symptoms. Again, choosing a center where you have very experienced doctors that are performing these procedures is really important, because when you go to a center like ours where thousands of procedures have been done, and the doctors who have been trained, all fellowship trained people, fellowship teachers, et cetera, you know, the incidence of damaging the vagal nerve in these settings is very, very low, well, much less than 1%. So while it's possible, it's pretty rare, and it's happened. Fortunately, we have a newer procedure that's also endoscopic that's come out called GPOEM, gastric peroral endoscopic myotomy. And that can be done through a scope where we can open up the end of the stomach for patients who have a condition called gastroparesis. Gastroparesis means weak stomach. Okay, so if you can get that from diabetes. There's some people who just get it. We don't even know why. Their stomach doesn't empty well. It doesn't pump. It doesn't grind food anymore. And they can benefit from that procedure. Or, as this question came up from this particular person, it could be damage due to previous surgery, in which case we can offer a procedure endoscopically to help that patient drain their stomach and get back closer to normal.
Perfect. Well, we're coming at the end of all the questions, and we've discussed everything. I just want to, before we conclude, want to ask you if you have any advice. I think you've given some great advice throughout this whole talk, actually, but if you have any additional thoughts or encouragements for people that may be suffering from GERD and acid reflux, what would you say to them?
Yes, I can't stress enough the importance of just picking up that phone, going on the website, and making that initial contact with a nurse coordinator to inquire about it. You don't have to commit yourself, but if you speak with them and they talk about some of the things that I talked about tonight and how they do a one-day evaluation, how you can have an outpatient procedure if you're a candidate. Our patients tell us all the time that they wish they would have done this years ago. Why? I didn't know it was going to be that good of an experience. I didn't know that the surgery was going to be that easy. And I'm of course very grateful for it, but I just wish I would have done it a long time ago. So when I hear that a lot, I think the advice I can give is do it.
Yeah. And have these TIF talks is to really educate the community out there that there's options, right? There's things that you can do. You don't have to keep suffering, and you just need to be an advocate for yourself. And we really appreciate you being here and educating the community about everything. So remind everybody where you're located, and if someone wanted to schedule an appointment, they can even schedule telehealth with you for initial consults, right? I know we have, if you're in the Minnesota area, we have the address and phone number up on the screen, but maybe you can just remind everybody, how to get.
Well, a lot of people are using websites now, and there is one. It's not Minnesota, it's MN, which is our Minnesota, mnheartburn.org. So if you go to that, you will see that there are two different sites. And one is toward the east and one is toward the west. And maybe you've already been in that healthcare system and you're comfortable with one or the other. If not, call one of those nurse coordinators the closest to you, and come on in and see us. We've got actually six experts, because we have a fellow who studies with us for a whole year. There's two fellowships here in the state of Minnesota. One's at the Mayo Clinic, and one is ours, and I'm the fellowship director of that. So we have 5 faculty doctors and 1 fellow here, and then we have a big team of people, and we will take really good care of you. So just come on in and get it done.
Fantastic. So if you are in the Minnesota area, you know how to get a hold of Dr. Severson. If you're not, you can go to gerdhelp.com, and we do have a physician finder on there, so you can put in your zip code, or you can search by state, and you'll be able to find a TIF specialist in your area. And thank you so much. It's been a pleasure talking to you tonight. We really appreciate you taking the time to be on here. And to everybody watching, thank you for joining us this evening. And I hope everyone stays safe and have a good evening, and we'll catch you next time.
Thank you, and Merry Christmas.
Yes, same to all. Thank you.